కనిపిస్తుంది ఇప్పుడు? స్క్రీన్ కనిపిస్తుందా?
yes.
ఓకే. సో టుడే రెండు టాపిక్స్, ఒకటి స్లో ఫ్లో ఫినామినా, ఇంకోటి బయోరిసబుల్ స్కాఫోల్డ్స్. ఓకే. సో coronary no reflow is the inability to perfuse myocardium after opening of a previously occluded or a stenosed epicardial coronary artery. So the
This
main
is from which book?
pathophysiology, TOEFL.
TOEFL, okay.
ఓకే. రిగార్డింగ్ ది రెండు, ఒకటి టోపోల్, ఇంకోటి అప్డేట్, మొత్తం నేను రాసింది చూసుకుంది ట్రయల్స్. ఓకే. సో ద నో రీఫ్లో ఇస్ సస్పెక్టెడ్ టు బికాస్ ఆఫ్ కాంబినేషన్ ఆఫ్ వన్ ఈజ్ ఎండోథీలియల్ డ్యామేజ్ and platelet and fibrin embolization, vasospasm, and tissue edema that overwhelms the coronary microcirculation. If the reperfusion related injury is hypothesized to contribute to no reflow, like a microcirculation is obstructed by the neutrophils or platelets, then the flow, no coronary phenomenon is one of the most pathophysiologic thing anamata. అందుకనే మన మైక్రోసర్క్యులేషన్ అబ్స్ట్రక్ట్ చేసే ప్లేట్లెట్స్ కోసం ఎపిక్సబాన్. ఓకే, దీస్ ఆర్ ద థింగ్స్ విచ్ ఆర్ ఏడిఆర్ లైక్ విచ్ ఆఫ్ లైక్ vasodilation. These are the things why they were used. So the coronary no flow phenomena lo the most important is risk ఇది ఒకటి damage to the endothelium, platelets and fibrin embolization and vasospasm. So the risk factors for the coronary reflow phenomena are, there are 5 risk factors. One is high thrombus burden, cardiogenic shock, hyperglycemia, leukocytosis, or any increase in the reperfusion time, like the procedure to the onset of the symptoms, like short door to balloon time. Hello, inpisunda? Yeah, so prevention can be done by 4 things. One is short door to balloon time, that is decreasing the reperfusion time, optimal blood pressure, optimal blood sugar. There is prophylactic intracoronary dilators. There are some studies which says prophylactic intracoronary dilators may reduce the coronary no flow phenomena, and in thrombus aspiration if it is a high thrombus burden. Okay, these are the 5 risk factors which we should think of. Next. So these are the coronary no flow phenomena. The first prevention, what I said, is short door to balloon time, optimal blood pressure should be maintained, optimal blood sugar should be maintained. Statins, there are prophylactic uses, there is some studies, and prophylactic intracoronary dilators and thrombus aspiration. So after the prevention of these things, we can prevent 4 things. One is infarct expansion, early ventricular arrhythmias can be prevented, early congestive heart failure, and adverse LV remodeling, including the LV dilatation. Okay, Nara?
What are the prophylactic intracoronary dilators?
చెప్తాను, అది నెక్స్ట్ దీంట్లో వస్తుంది. So these are the things. Okay. This the diagnosis of the no reflow. Once we have discussed about the pathophysiology, that is endothelial damage, fibrin, platelets, and vasospasm and tissue edema. Second is microcirculator obstruction with the neutrophils and platelet plugs. And third thing is risk factors. Next, how to diagnose of a non-reflow phenomena. One, it is what we routinely use, that is a TIMI grade score, like 0, 1, 2, 3, what you mentioned. And next is the TIMI frame rate. And another is the myocardial blush score, and another is the myocardial contrast echo. So these things were meant better to diagnose of a no reflow phenomena. Whatever the studies they mentioned about if any drug, how it improves the microcirculator phenomenon was phenomenically demonstrated by the myocardial blush score with and the contrast echo of the myocardium. Okay, na? So there are some prevention factors of a non-reflow phenomena. Like there are some trials which say if you intervening of a saphenous venous graft, using of a distal protection device can prevent a no reflow phenomena. When you're performing a rotational atherectomy, especially in right coronary artery, routine use of nitroglycerin, verapamil, or heparin in combination with the flush solution can prevent the no reflow phenomena. Considering treatment with a GP2B inhibitor before the PCA or during the PCA can prevent the no reflow phenomenon. And another thing is minimizing the balloon inflation and considering direct stenting in patients with a bulky atheroma or a saphenous venous graft, or pre-treatment. These in the pre-treatment with a prophylactic prophylactic intracoronary dilators like verapamil or adenosine can prevent. Some studies quoted, and there is an aspiration thrombectomy for thrombus-laden lesion. As of ESC guidelines, thrombus aspiration is a class 3, but still if it's a high thrombus burden, we can use of a thrombus aspiration catheter.
Routine thrombus aspiration is class 3, not
Class
Class
3.
3, yeah. Not routine aspiration is class 3. Okay now. So
Trials
distal
ఏమున్నాయి?
protection
Thrombus aspiration trials.
total అవన్నీ ఉన్నాయి చూపిస్తా.
Tapas and test.
total,
టపాస్
Toast.
టోటల్ గోస్ట్
టేస్ట్ కాదు టేస్ట్.
Taste.
Taste.
Okay.
టేస్ట్
Tapas and
టేస్ట్ ఉంది, ఇంకోటి గోస్ట్ దాని పేరు
Tapas.
గువాస్ అని ఒకటి ఉంటది, వాడు కూడా సేమ్ ఇదే చెప్తాడు, థ్రాంబస్ ఆస్పిరేషన్ వల్ల సివియర్ రిస్క్ ఎక్కువ ఉంటుందని, ఎస్పెషల్లీ నా రైట్ కొర్నరీ ఆర్టరీ. ఓకే, సో ప్రివెన్షన్ అనేవి 5 పాయింట్స్. ఒకటి డిజిటల్ ప్రొటెక్షన్ డివైస్ ఇన్ సఫినస్ వెనస్ గ్రాఫ్ట్స్. When performing rotational atherectomy, you should, along with the rotaflush solution, we have to give verapamil, heparin or nitroglycerin. And another is GP2B3 inhibitors during the PCI, or before or during the PCI. Minimize the balloon inflation. Direct stenting is preferred. Pre-treatment with verapamil or adenosine for the prophylactic intracoronary dilators. Aspiration thrombectomy for the thrombus-laden lesions. Okay now.
2B3 inhibitor trials ఏమన్నా ఉన్నాయా?
చెప్తాను, ఎందుకు కంగారు, ఇంటికి వెళ్ళిపోతున్నావా? సో ఇప్పుడు ట్రయల్స్. ఓకే, ద ఫస్ట్ ట్రయల్ వాట్ ఈస్ ద డిజిటల్ ప్రొటెక్షన్ ఇస్ ద సేఫర్ ట్రయల్. ఇదేం చెప్పిందంటే డిజిటల్ ప్రొటెక్షన్ ఇన్ ద కాంటెస్ట్ ఆఫ్ సఫ్నస్ వెనస్ గైడ్ డిక్రీస్ ద రేట్ ఆఫ్ నో రీఫ్లో ఫినామినా. కంపేర్డ్ దే హ్యావ్ కన్ఫర్మ్డ్ పెర్ఫార్మింగ్ PCI వితౌట్ డిజిటల్ ప్రొటెక్షన్ 4.8% విత్ 9.7% కన్నా రిజల్ట్స్ బాగున్నాయంట దీంట్లో సేఫర్ ట్రయల్. హలో,
Yes, sir. Yeah.
Okay. Next is Edimer trial. No చెప్పింది రసంలో. Administration of Ebixaman prior to PCI STEMI decrease the proportion of the patient with TIMI reflow both in pre and post PCI. And these last దీంట్లో స్టడీ చూస్తే there is an increase in left ventricular ejection fraction and decrease in the composite endpoint of the death. This trial of Edimer, which is of Ebixaban. Okay. Next is TAPAS. Thrombus aspiration. మొత్తం థ్రాంబస్ ఆస్పిరేషన్ ట్రయల్స్ లో టపాస్ ఈజ్ ఓన్లీ ద పాజిటివ్ ట్రయల్. టేస్ట్ అండ్ ఇన్ఫ్యూజ్ ఎంఐ వెన్ కంపేర్ టు టపాస్ ఈజ్ ఇన్ఫీరియర్ ద ట్రయల్. థ్రాంబస్ ఆస్పిరేషన్ డ్యూరింగ్ పీసీ అండ్ acute MI, aspiration thrombus improved the markers of preperfusion such as myocardial blush score and ST segment resolution. But with the same randomized control, they have extended this data and they compared of a taste with infusion MI trial. They compared with the tapas, then the tapas said that it is inferior. Thrombus aspiration with infusion of Ebixaban before PCI didn't give any comparison with the TAPAS trial. These are all negative trials. TAPAS is the only trial which says of a positive thing. And largest prospective trial is the total trial, which is of no benefit in thrombus aspiration. Hello?
Okay.
వినిపిస్తుందరా?
Okay.
So next is the Society for the Cardiovascular Angiography Intervention suggests the management of a neurofiman. The first line management is adenosine. There are 3 drugs which are approved in first line management. One is adenosine, verapamil, and nitroprusside. So adenosine trial endante Amsterdam ADAPT trial, which shows that adenosine of 10 to 20 microgram bolus, which will, before the administration of nitroprusside, you have to give off an adenosine dose, which shows of a myocardial blush with around the contrast echocardiogram shows an increase of a flow, the TIMI3 flow in ADAPT trial.
Amsterdam and ADAPT
Amsterdam.
different trial.
Amsterdam and ADAPT are 2 different trials, which says that
Okay.
adenosine is having a positive in the no reflow phenomena.
Okay.
అర్థమవుతుందా?
Yes.
Okay. Next is verapamil, which was in 100 to 200 microgram bolus. This was myocardial contrast before and after PCI. Verapamil lo myocardial contrast echo చూస్తే there are no trials quoted, but they said that Fusit et al. Said that when compared to verapamil and nicardipine is more potent compared to verapamil. But with nicardipine, there is more of hypotension. So verapamil, while you using a verapamil, you should be taking care of the pacing, because blocks were more common with verapamil, and myocardial contrast echo shows before and after PCI. Verapamil shows a good reflow phenomena. And nitroprusside. Nitroprusside is a 200 microgram bolus, up to 1000 microgram total dose we can go, which is often after adenosine gives a better result. Hello.
Okay, nitroprusside should give after adenosine.
After adenosine. Okay.
Okay.
Next is the evidence less strong drugs are what we mentioned: nicardipine, nicorandrel, epinephrine. Nicardipine was more potent than verapamil, and nicorandrel, while mentioned about in update that nicorandrel and nitroprusside and these adenosine, which could be given with the distal with a microcatheter or of a thrombus aspiration or of a the cutting balloon assisting thing, like while you perforated balloon technique, you have to make a perforation at the balloon, and along with the indiflator you have to deliver the drug distally, which shows of a more good phenomena.
What is the mechanism of epinephrine? Like epinephrine is alpha means adrenergic
Epinephrine,
agonist.
actually epinephrine dosage is, besides it is an exerting at high dose, it is having a beta 1 agonistic properties that increases both inotropic and chromotropic stimulation of the myocardium, but epinephrine at low doses except a more potent beta receptor agonistic properties that mediate coronary vasodilation. This is the drug which we have to prepare in 1:1000. First you have to dilute one vial in 1000 ml, and again in that 1000 that 1 mg you have to dilute in 100. Then you have to give the 10 ml, then it will be equal to 100 micrograms. So
How I
epinephrine
remember
at
is take 10 mg in 10 ml, then
10 ml.
out of that 10 ml take 1 ml, again dilute
Hmm.
it in 10 ml, then give 1 ml out of that.
అది ఒకటి వాట్ దే సే ఇన్ అప్డేట్ అంటే like there is no specific dose for these things, like
3
100
times you have to
microgram and
dilute 10 ml.
3 times you have to dilute. And
Means
the
1 ml
study
you have
which
to take 10 ml,
the
1 ml.
study which caused about epinephrine is restore shows a
Restore,
better flow
okay.
phenomenon. Restore
So it
drug.
is because of beta 1 agonist property at low
So
dose.
when epinephrine given at high doses, it exerts beta 1 agonistic property that increase inotropic and chronotropic stimulation. At this low dose of exerts a beta receptor agonistic property that mediates coronary dilatation.
Okay.
Okay, na?
Okay.
And never shown to be effective intracoronary nitroglycerin and stunt placement inside of original
బీటా
cirrhosis
అని చెప్తున్నారు
and
ఏంటి? బీటా 1
అర్థం కాలే.
రెండు బీటా అని చెప్పారు. లో డోస్ హై డోస్ కి
అదే
తేడా
కదా.
రిసెప్టర్స్.
Mm.
లో డోస్ ఎపినెఫ్రిన్, హై డోస్ ఎపినెఫ్రిన్ రిసెప్టర్స్ ఏంటి?
See, జనరల్ గా మనకు ఐనోట్రోపిక్ క్రోనోట్రోపిక్ ఎఫెక్ట్ ఉంటుంది ఎపినెఫ్రిన్ కి.
అది ఓకే.
ఐనోట్రోపిక్
Low
ఫోర్స్
dose
ఆఫ్ కాంట్రాక్షన్ రేట్ ఇంక్రీజ్ చేసేది. They said that at lower doses the beta 1 agonistic property of the distal vasculature is more potent compared to the other effects. Lower dose, ఈ హయ్యర్ డోస్ కి మన ఇప్పుడు ఇంట్రాకోర్నరీగా ఇచ్చే డోసు చాలా తక్కువ, which
అది
makes a
ఓకే.
more of coronary vasodilation.
లో డోస్ లో రిసెప్టర్స్ ఏంటి, హై డోస్ లో రిసెప్టర్స్ ఏంటి అని అడుగుతున్నా.
నేననేది ఏంటంటే హయ్యర్ డోస్ లో ఇట్ ఇంక్రీజెస్ ఐనోట్రోపిక్ అండ్ క్రోనోట్రోపిక్ ఎఫెక్ట్. రెండిట్లోనూ బీటా 1 రిసెప్టర్ అగోనిస్టిక్. బీటా 1 కదా వాసోడైలేషన్. వెజల్ మీద ఉండేది ఓన్లీ బీటా 1 కదా.
ఓకే.
నేను అనేది అంటే డోస్ డిఫరెన్స్ చెప్తున్నాను. ఇంట్రా కోర్నరీగా ఇచ్చే డోస్ వెరీ మినిమల్ డోస్, which will have only vasodilator.
సేమ్ రిసెప్టర్స్ అని.
సేమ్ రిసెప్టర్స్.
ఓకే.
ఓకే. సో ఫస్ట్ లైన్ మేనేజ్మెంట్ వచ్చేసరికి ఎడినోసిన్, వెరాపమిల్, నైట్రోప్రూసైడ్. ఓకే. మన సీక్వెన్స్ ఎప్పుడు ఎడినోసిన్ తర్వాత నైట్రోప్రూసైడ్ ఉండాలి. ఎడినోసిన్ కోట్ చేసే ట్రయల్ ఎంస్టర్డ్ అండ్ అడాప్ట్ ట్రయల్. నైట్రోప్రూసైడ్ ఆఫ్టర్ ఎడినోసిన్ యూ హ్యావ్ టు గివ్ బెటర్. And next, evidence less is strong is nicardipine, which was more potent, but there is more chances of hypotension. The trial no benefits with nicardipine. Next is nicorandril and epinephrine, which shows better of a restore better flow. Never shown to be stunt placement and thrombolysis and intracoronary nitroglycerin. Okay now.
But we use nitroglycerin commonly.
So more recent trials, they are the phase 3 trials are, one is GLP-1 analog, that is liraglutide, which is of a phase 3 trial, and ischemia with an hypothermia, and a perforated balloon technique, which is of deliver the drugs through adenosine, through the perforated balloon, adenosine, nitroprusside, nicorandril, what I mentioned. Whatever the drug you give a distal flow, better to deliver through a microcatheter or a thrombus aspiration or a perforated balloon. but during a perforated balloon, what they mention, the air sucking effect will be more. So you should be very careful while delivering drugs through the perforated balloon. And recently, one study of 93 patients was going on. There's an autologous blood transfusion. Minimum amount of autologous blood transfusion is 100 to 200, 120 ml. Showed successful restoration of TIMI-3 flow in of 82.7% patients. This is an ongoing trial. They said that autologous blood transfusion, if no other patient, if the patient is of more of an hypotension, no other drug can be used, you can use an autologous blood transfusion. Hello.
Yes.
Okay, Nara.
Okay.
So trials. So first one choste, the thing is. So if the coronary reflow anedi, first thing is pathophysiology is thrombus, platelets, and neutrophils, and microcirculatory circulation by the chemokines and vasospasm, and which could be prevented by the short balloon time, optimal blood pressure, blood sugar, statins, and prophylactic intracoronary dilators, and thrombus aspiration if present. If by early preventing, you can prevent the infarct expansion and ventricular arrhythmias, and early congestive failure and adverse LV remodeling. And next, whatever the diagnosis, TIMI grading, frame, and myocardial blush and myocardial contrast echo. Prevention in saphenous vein, you have to use distal protecting device. The trial is safer trial. While performing rotational therapy, you should additional use of nitroglycerin, verapamil, and heparin in combination with the flush solution. Consider pre-treatment with of any GP2B3 inhibitors during PCI in patient with acute coronary syndromes. Minimize the balloon inflation